Save your tears. It's okay. It's all right. So, I know. Tears of joy. I don't know. All right. Again, not going to rush through this. If we don't finish this today, we'll start off labs tomorrow with just finishing it out, and then kind of split and separate and start giving you guys some fun practice, kind of scrolling through CT scans, finding different anatomies, things along those lines, to prep you for knowing how to use this stuff, how to actually do it when you're in phase 2 and you are scrolling through this, so the first time that you're doing it isn't in phase 2. And that's kind of how the lab is going to be structured. Is going to be playing with CT scans and figuring out. Remember how we talked about there's different windows for different things to be able to see certain things better. You're going to have the opportunity on some of these scans to pick what window you want, because some stuff might not be available to see on a particular one. You can see it better under the lung window or the bone window or something along those lines. So, okay, so intermittently you get a chance to kind of play with it up here, and yes, in front of everybody, so they can all watch it. But questions about yesterday? No? Don't know? Not sure? What's sight and then me that whole time after? Okay. Good. You guys be good. Yeah, you got like 5 days to study for mine. That's unique. It's unique. Radiology has never been the last test of the semester, so there's never been. So I'm excited to see how well you guys do and everything with 5 days to really kind of focus in on it. Usually people try to cram this into like a weekend of all this stuff, and so I don't recommend studying test to test, but you guys already have your system by now. Still don't recommend it, especially when you're over there. So when I've done not study test to test, right? So I used to study test to test, and I did it this way, right? In the aspect of how I would do it. I don't know if I told you guys this before. I took 10% of my time every night after I got out of class for the day. I went home, and all I did was just review the slides we covered that day in lecture, no matter what classes it was. It wasn't a full-on commit to memory. It was just let me read through them again to solidify what I heard in lecture. And that was technically study everything every day, right? Because I went over that. Then I broke up the rest of my study time into 60% the upcoming test and 30% the next test. And that was how I split it up. So that way, by the time I got through whatever test, we'll say if this is the middle of the semester, whatever the Friday test was, when I went to the weekend to make that next one, I had already spent 30% of my time looking at it, so it wasn't like trying to cram everything in just the 2 days, right? And then I would just kind of did that shift. So that was a me thing. It technically wasn't everything every day, but if I just would review the day of. And so, but that's, over there is going to get crazy. And the reason I say that is trying to cram for like an endo test or a pulm test or something like that, or a cardio test in just 2 days. If you haven't even looked at it or touched that stuff, over there is going to be daunting. So see what you can manage. But really, as long as whatever you're doing, you're passing tests and it's working, stay with you. Right? You guys do you. That's what we want to see is just pass. Okay. We're going to look at stuff like this. Right? More abdomen pelvis stuff. This here is a really severe dilation of the intestines. This is not a pneumoperitoneum like you looked at towards the end yesterday. How do I know that? I got full-on circular bowel wall slices here, right? You can see the connection there of some of that tissue sometimes. Can you always see that on just the one image? No. You'll have an actual full CT to look at it. And that scout, this is that scout I told you about. This is not a whole body x-ray. This is what they get before the CT scan. It scouts everything. So what this ended up being is a chest, abdomen, pelvis CT. So what happens is they scout the whole body, and then the CT tech puts a little blue box right up here and right down here, and then the scanner actually does the actual CT with the high amounts of radiation through the blue box of what they kind of set up. All right, so that's what this is. This is not just a regular x-ray. This was that scalp film so they could see where they're going to do the CT from. But more GI and then some GU imaging. Small intestine, large intestine, spleen, liver, pancreas, gallbladder. Guys, once we get down here, there's not a whole lot. This goes by pretty quick because it's just a matter of this type of imaging we do, and here's kind of where it's at, because there's not a whole lot of spleen, liver, pancreas, or gallbladder specific imaging that we talked about yet, or that we're going to, because X-ray can't really see it that well. So the meat of it is going to be the intestines, starting with small. and your anatomy. The lovely, pretty anatomy and physiology book picture that looks nothing like anything that we're actually looking at, because this is just how they draw it, right? But you use this, you kind of get an idea of where the small intestine at least sits. That's pretty accurate, and kind of see how those loops all kind of lay on one another compared to the generalized shape of that large bowel. But I don't want you to marry to that. I want you to use the difference between that valvular conaventes, that haustra, or kind of what that looks like to help distinguish between the large or the small bowel. So much like the esophagus and the stomach, we're going to look at ulcerations, perforations, dilations, narrowing, obstructions, all these things in the small intestine. So now, let's think about this. We did generalized abdominal imaging, right? We looked at your generalized x-rays. If I'm looking at specifically the small intestine, it doesn't really stand out on a normal patient a lot of the times unless it's dilated or distended or there's an obstruction or an ileus or something like that. So we're going to need to use things like the contrast to make it stand out sometimes, right? So we're going to talk about x-rays and then talk about some of these oral contrast studies and what we're kind of looking for, okay? So in general, opacification distension of the bowel lumen is necessary for proper evaluation of the bowel. So I need to have some of that. So if I'm truly just trying to evaluate the small bowel, not my, I don't know what's going on, I'm getting an x-ray to see why you have abdominal pain, that's different, right? But once I've determined, I think this is a small bowel issue, I need to have some type of contrast, opacification is what's on there, but really the contrast to create that difference between the inside of the bowel and the wall of the bowel. Because I can't make it out on a normal x-ray if everything looks normal, okay? And a good example of this is here. So on here, right, we looked at normal bowel gas patterns. We haven't seen a whole lot where you're actually able to trace out the full kind of small intestine. Now this isn't necessarily distended or dilated, but what you can see is that some of these folds here are a little bit thickened. The mucosa is a little bit thickened. I can see some tongue-like projections, which we couldn't see on the regular ones, the normal x-rays. And when you look at a lot more of these, you'll realize that that is abnormal. That will kind of stand out to you. But I have no idea why or how severe this is because it's just an x-ray, right? I can't make out what part of the small bowel that is, what's going on with that. So there's two things I'm going to need to do. I'm probably going to give contrast, and then I'm probably also going to get a CT so I can get more details. And that's what's going on down here. And then you can see how thickened the mucosa is, right, around this area of the small bowel. I mean, you can see a contrast, that's all contrast inside, that's the oral contrast, and just look at how thickened that mucosa is, all right? Another hint that there's going to be some type of inflammation or something else going on is something called fat stranding. We'll look at what normal looks like here in a little bit, but what fat stranding is all this hazy, kind of noisy kind of lines, right, technical terms, hazy and noisy, kind of little lines in the subcutaneous fat. It's fat stranding. So fat is darker, right? It's more radiolucent than your soft tissue. So all of this dark stuff right in here, this is subcutaneous fat, okay? So all of this dark stuff in between the soft tissue and the intestine, that's subcutaneous fat because it's more radiolucent. When you start getting some of these wispy kind of grayish lines in the subcutaneous fat near an area of what looks like edema or swelling, that's called fat stranding. That's inflammation or more fluid in that subcutaneous fat due to whatever's going on in that area of the body. So sometimes that can be a clue to help you hone in on a specific area and maybe look for an abnormality that's not super obvious, right, on your first kind of scroll through. Like, oh, hey, I see the fat stranding. So we have some up here, right up above the intestine, right up here. So some right up here, some fat stranding, if you take a look. And then we got some kind of surrounding down in here. Not this guy. This guy is a vessel, right? It maps out like a tree branch. That's a nice little vessel. This is the vessel coming down, vasculature. But then around it, I got kind of all these little hazy kind of lines of inflammation down around here and up in here. That's going to be your fat stranding, some type of inflammatory process. In this particular case, it says colitis on there because that's what this patient has. They're having an episode of colitis, inflammation of the bowel, right? But it could be anything causing inflammation or infection, right? And then you would look for any kind of extraluminal contrast, or any type of contrast spilling out of the intestine. That would be signs of a perforation somewhere. That's not on this. There is no perforation here. Yeah.
How do you tell the difference between just this sort of fat
As far as
like has a ton of visceral fat, and that's not just normal excess visceral fat.
so even if they have excess visceral fat, or let's say they have a lot of adipose tissue, it's still going to be more radiolucent than the surrounding stuff. The amount, unlike an X-ray with a CT, right? The amount of adipose tissue does not change the overall density of the picture on the CT. So if they're 400 pounds, you're just going to have a lot more of this separating the organs. To be honest, it's a lot easier to read a CT on the larger patients because they have so much extra visceral fat or adipose tissue that it actually, the organs are nicely separated. They're surrounded by a lot of that more radiolucent view or color, basically. And so it's a lot easier to make the organs stand out in those larger patients, because that's what happens is all just in here. So even if I have a 500-pound patient versus a 160-pound patient, the density of the subcutaneous fat or the visceral fat is not going to change. Does that answer your question? Okay. So you'll still kind of have that difference in that aspect. As far as how to tell the vessels from the fat stranding, right? Scroll through and follow it. If you can trace it back to the aorta, then it's going to be a vessel in some way, shape, or form. If you can't trace it back in a nice linear line when you're scrolling through, that's how you stand out and go, hey, that's definitely some fat stranding in that aspect. And in real clinic, you'll be able to do that. If I give you something like this and I want that to stand out, it will be an image to where the vessel clearly is going back to something. So you're like, nope, that's a vessel, that's separate, that's the fat stranding. If I were to give you something like that, no, I'm like 60% complete with the test. So, all right. Small intestine. So here's something called a small bowel follow-through. Okay, we don't use this very often anymore, but this is a normal study. Okay, small bowel follow-through. The reason we don't use it very often anymore is, again, CT gives us more information, right? But if you don't have a CT scanner, this is what you're going to do. You make the patient drink the contrast. Here's the stomach. Here's the stomach. And this test will take hours. Hours. Because what happens is they drink the contrast, and then the x-ray tech is taking pictures at timed intervals, watching it flow through the intestines until it gets to the ileocecal valve, and then the study is done. And so what you would end up doing, or the radiologist end up doing, is comparing all the pictures as it goes through the small bowel, because every image is going to have look a little bit different, and you're looking at different sections of the small bowel, and you're following it all the way through to the large intestine. So that's a small bowel follow-through is what it's called. Okay. So what makes this normal? I mean, it's just, look at all the small bowel. We'll look at the abnormalities. The abnormalities are a lot easier to pull out than kind of explain the normal study because we got some contrast here, we got more here. It's all just a tiny thing, and these are all going to look a little bit different. Pneumoperitoneum. Which side? Right side. Is there one on the left? I don't know. Maybe it's sitting behind the gastric bubble, not sure. That's why it's right there. So that means we got a perf somewhere. So if we're concerned about a perf and we want to do a small bowel follow through, what contrast are we not giving? Barium. Good. Okay. This is just kind of like a review of the x-rays, right? We kind of talked about these studies kind of yesterday, what they look like. So dilation due to small bowel obstruction. Right? How do I know it's small bowel? Valvular conventase. Boom, 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 boom. The yellow line's hiding some of them. But then I have multiple loops sitting on top of one another. All right? Got my valvular conventase. And then I got multiple loops sitting on top of one another. Right? Yes. I have some gas still down here. When I told you, well, wait, there's like no gas down there for the obstruction. It just hasn't got there yet to start in the small bowel, right? So that's where your physical exam findings will help lead you towards that. If it's an obstruction, we're going to have hyperactive bowel sounds, squeezing, colicky pain, those kinds of things. Maybe this is early on and it hasn't expunged all of that gas yet. They definitely haven't used the bathroom anytime soon if there's an obstruction, but other clues that can lead you towards obstruction versus ileus is the physical exam findings as well. Yes, sir?
On the left side of the image, the patient's right side, like one-third of the way down to that margin on the top of it, right there, is that margin test starting to dilate?
Yep, That is absolutely the large intestine here. There is still some, so you can see this is the ascending colon, okay? And so it just goes to show you that we have the small bowel obstruction. It's not necessarily starting to dilate yet, but there's just going to be some air and some stool that hasn't worked its way out yet, right? It will eventually work its way out. And that kind of matches up with the fact that I still have air in my rectal sigmoid. This is an early on obstruction as far as in terms of expunging all of that air and stool out of that large intestine, right? And that's why I use this one to kind of bring you back to what are the physical exam findings? What are you hearing on physical exam? What's going on? That's what's going to help distinguish you between the obstruction and the ileus. Okay. Small bowel issues. We talked about obstruction. Post-surgical adhesions being the most common, right? Post-surgical adhesions being the most common. Here's the fun part, which we didn't touch on yet. The ileus, recent abdominal surgery. Great, right? So another clue of distinguishing between these two things, time frame. Adhesions take months to years to develop complications. Adhesions do not happen overnight. They do not happen over a week to 10 days. Adhesions take a hot minute. Ileuses are usually within 48 hours of the surgery. Why? Because an ileus is inflammation, trauma to the bowel, it's agitated, it stops working because it's painful. That's going to happen pretty quickly. It doesn't like the fact that there's inflammation. It doesn't like the fact that you cut it open or we're digging around in there doing abdominal surgery. So your time frame and your patient history is going to be a key discriminating factor if you're looking at this, and let's say there's not physical exam findings yet because you just got a report, but you knew they were post-op. When were they post-op? Did they have surgery within the last 48 hours? I'm leaning towards ileus. Did they have surgery 6 months ago, 3 months ago? I'm leaning towards post-surgical adhesions, and now it's obstruction. Okay? So that's where I kind of say, like, they look the same, but there are a lot of key distinguishing factors that you can use to try to separate in your mind which one it could be. Patient history is huge. If you really need more, donut of truth. CT. Tells you everything. Okay. Here's another picture of an obstruction. Okay. Parachute sign or just those air fluid levels, right? On that upright film, multiple loops of dilated bowel with those flat horizontal lines. Flat horizontal lines, your air fluid levels, multiple dilated loops, a lot of physical exam findings, and the air fluid levels are going to tell you more likely small bowel versus large bowel because we typically don't have any in the large bowel. The one we saw that looked like it, that was that transition point due to the tumor that was in the large bowel causing the obstruction. Right? It wasn't an air fluid level. Okay, Crohn's disease. Crohn's disease. All right, it affects the entire GI tract. You usually see it in the colon for the most part, but it does affect the entire GI tract. Look at all my symptoms. Oh, fever, weight loss, fatigue, nausea, anorexia, abdominal pain, diarrhea. Diarrhea is the big one. If you're not having diarrhea, for the most part, you can probably not consider Crohn's disease right now. It's an inflammatory bowel disease. It's a subset of the overall inflammatory bowel diseases, Crohn's. Okay. You can have some rectal bleeding, but not as much as like the ulcerative colitis, which we'll talk about a little bit. Biggest thing for this, right, we already know X-ray is where you're going for your initial study, but your CT with contrast is your study of choice, both oral and IV contrast. We're not going to get into oral and IV on the exam, but when you guys order this in clinic, when you order it with contrast, you're the one telling them, do I want just IV contrast? Do I want just oral contrast? Do I want both? So that's why I put that on here for your phase 2 when you're ordering images and stuff. Here, we're just dealing with CT with contrast, CT without contrast, right? We get into the PE study of CT with contrast or CTPA, pulmonary angiography, whatever the case may be. So yeah, you could do the small bowel follow through, but right? If you do a barium enema, or looking at the CT, you're going to see some thumbprinting in that large bowel. We're going to take a look and see what that looks like. But ultimately, what you're going to see is narrowing of and ulceration of the terminal ileum. All right, string sign, and it's in a certain area. We'll take a look at it, and the fistulae. Okay, and then you're going to see some narrowing of the terminal ileum. All right, string sign, and it's in a certain area. We'll take a look at it, and the fistulae. Okay, string sign, and it's in a certain area. We'll take a look at it, and the fistulae. Okay, string sign, and it's in a certain area. We'll take a look at it, and the fistulae. What type of bowel is this that we're studying for Crohn's disease? We're in the small bowel section. It can happen in the large bowel, but focusing on the small. You'll see why I say that, and I made that point here in just a second. String sign. Where is this? This is your terminal ileum going into your ileocecal valve before it gets to the large intestine. The reason this is so thin in this area, and look, what area is it in? Where is it at? We're in over our right ileum, right? And it's also, so right in that area, it's so swollen and angry and inflamed that this is the only pathway I have for the contrast to get through right now in the Crohn's disease. I can't make it out, it's an x-ray, so I can't see the inside, I can't see the actual soft tissue, but I can see how the contrast is supposed to flow. So you get narrowing of that terminal ileum heading to the ileocecal valve before you get to the large intestine. I say this because we are going to look at something very similar in the large intestine that is something else. Okay? It looks a little bit different, but I don't want you to get this string sign confused with the large intestine thing when we get there. There it is, large intestine. So, string sign, Crohn's disease, let's go back. Diarrhea, right? Paige doesn't have diarrhea. I don't have Crohn's on my differential. Okay? Don't have Crohn's on my differential, but I'm going to be looking for the string sign in that distal ileum, and proximal colon is the most often involved. The colon is a word for like the entire large intestine, not just the rectal area, the rectosigmoid colon, the transverse colon, the ascending colon, right? It's a generalized word. So technically distal ileum, and then it will involve that ascending or that proximal colon area after the ileocecal valve, and your telltale sign on x-ray is this string sign. So for diseases of the small bowel, we basically looked at obstruction, ileus, and Crohn's. Don't think there were any other more specific ones in there. Right? So not a whole lot of these. You'll learn all that pathophys and all those other diseases in GI. I'm just teaching how to find the abnormalities. Large intestine. Same picture, only focus on a different area. We're going to look at all the same things. Okay, here's a normal study. Look at how my large intestine is not the perfect shape from the picture. It's supposed to go up and come across and come down. What the heck? Everybody's built differently. What this is this is the picture of what's called a barium enema. Okay? Barium enema. It's actually a double contrast study. They use air as well. So how does this study work? So barium enema, they put the enema where the enema goes, they blow up a balloon, and they just use gravity with a bag full of barium, and it pours right into the large intestine. Now, the thing with the large intestine is, if I'm doing a large intestinal study, I want to be able to see all of these walls and the flexures and things along those lines. That can be tough if I just filled it with contrast, right? So, sometimes what they'll do is they'll have a little air bulb on the side, and they'll pump some air in the large intestine as well. And what that does is that creates this double contrast view, so you can kind of look at both, right? The air is not the contrast. The barium is the contrast. If I just put air in here, it's not going to do me any good. It's just going to look like dilated loops of bowel, right? So the contrast is the barium. Sometimes you can add the air to kind of expand it out a little bit, all right? And so we got a normal study. What is normal? For the most part, we got smooth walls, right? Smooth walls throughout. It's in the generalized shape of what the large bowel is. I don't see any outpouching. I don't see any perforations. All the contrast is held within the large intestine. Okay. I don't see any filling defects that aren't done by air or ulcerations or anything along those lines. So it's a fairly normal study with this barium enema. There's what my ulcerations look like for ulcerative colitis. Now go back and compare my normal. Look at how smooth, how crisp, how clear, how nice these barium enemas look when they're normal studies. Now look at my ulcerative colitis. It's almost like polka dotted, right? Right in there. You just see all the little kind of filling defects, all the little noisy kind of dots. Almost looks like there's kind of chunks kind of taken out. Those are the ulcers that are sitting in there. That's your ulcerative colitis. Okay? Your ulcerative colitis is going to have more profuse rectal bleeding. right? Because what's happening is it's inflamed, it's angry, it's shedding. It's kind of shedding that inner intestinal wall, and that's causing some blood in the stool. So ulcerative colitis, often, they will have diarrhea as well, but will often have more bleeding than your Crohn's disease. On top of that, look at where my image is, and look at where the image was for the Crohn's disease. Other side of the body, not quite the string sign. This isn't even a thing that's similar to the string sign, but not quite the string sign because it's a little bit thicker, but it's also large intestine. So those are clues between the two as well. We've looked at some of these already. If you have a perforation, you're going to end up with a pneumoperitoneum, right? That's what this area is up on here. And where's my perforation? Do I even have it on here? Bowel loop, yeah. I don't see the perforation on there, on this particular image. But when you have perforation, you get a pneumoperitoneum. I think we belabored that already. Perforation anywhere in the GI tract can lead to that. A lot of our pneumoperitoneum, guys, we're going to give you via x-ray because that's what we spent the most time looking at it for. And you're going to find that on x-ray way before the CT. So that's where I want you to learn how to see those things, but know that you can't see it on CT as well. All right, dilated large bowel loops. So let's take a look at this and let's figure out, how do I know it's large bowel versus small bowel? So first, I can kind of make my generalized shape, right? I don't have loops lying on one another. Although it comes down, it kind of has the generalized shape of the large bowel. It's not a bunch of loops kind of sitting upon one another. So that's step one of looking at it going, hey, I think this might be large bowel. Yeah, it looks like maybe I can have some straight lines all the way across here, right? But then when I look at the rest of it, I'm not seeing a whole lot of it. Maybe a small little Hauster here, right? Maybe a small one here. So small little Hauster here, maybe a small one here or another one here, right? I'm not having those continuous lines coming all the way across throughout the entire intestine. So that's another sign that this is large bowel over small bowel. Dilation is typically going to be due to an obstruction. Yes, most common is cancer. This one just happens to be due to an incarcerated inguinal hernia. That can happen as well. So that's one of the causes. But that's what we got, is we got an obstruction here. I can't really see down at the bottom to say that there's no stool or gas in that area, depending, because I mean it's going to be lower anyways, the obstruction, right? Because the inguinal hernia is down near the pelvic region. So that's everything behind it is backing up. But again, I'll have those physical exam signs that will help distinguish this from an ileus. Okay. Here's another one. What do I got here? I got obstruction, I got dilation of both the large and small bowel. Okay? So here's my large bowel. We kind of talked about that a little bit. Here's my large bowel. Here's my small bowel. Again, see those valvular conventes. See those kind of loops sitting on one another. Now, why do I have small bowel dilation in a large bowel section? Because it's backing up. This one is further on. Good, right? Because what do I have right here? What do we call this? That's my transition point. That's my transition point, right? Because the large bowel doesn't have air fluid levels. This is where my obstruction is. Right here. Still got a little bit of stool, or a little bit of air down there, but almost nothing down below, and this is my transition point. So large bowel, backing up, and here's my small bowel. So yes, you can have both, yeah.
So it would be named based on the point of obstruction?
Correct. It's named based off of where the obstruction is. Thank you, good point. So this is a large bowel obstruction, even though small bowel is affected, because that's where the obstruction is. Small bowel is only affected because of the backup, yeah.
So it looks like there's two transition points, but we can just use the most distal one.
Yes, yeah, this will be it here. This will be your transition point here. Here, it almost looks like, because if you look at this line here, it's kind of coming all the way across. So I wonder, and I don't know this, I just know I don't know what's going on with this patient here, but it looks like it's almost like a different kind of air fluid level, because the bowel kind of ends here, but then I still have that air fluid level there. So maybe there's some kind of edema going on, or other fluid in the abdomen. So he's talking about this air fluid level here, right? But if you notice, it goes past that intestinal wall. So they may have a buildup of some kind of, maybe there's some ascites going on as well, or some kind of buildup of fluid on that side as well. narrowing of the large intestine. Okay. Almost kind of looks like the ulcerations, but this is your narrowing of the large intestine. We did the baryomenema, right? And here's the thing, it flows backwards. So even more interesting that, because we're going backwards, right? That I have this narrowing of this area and then it's wide open throughout here. That means the contrast is going through here. It's not enough to dilate and actually go through that large intestine. So something is blocking this, right? It's not like, oh, the contrast hasn't made it there yet. No, it's very minimal. We go backwards. So we hit our descending colon first, rectosigmoid, then descending, then splenic flexure, transverse, and down into the ascending. We do the baryomenema because that's where the contrast flow is. So this isn't a delayed contrast flow. This is one of the first spots that gets it. So that's a narrowing of your large intestine, typically in your descending colon. Why is that important? Colon cancer is the most common cause, most common cancer of the GI tract, and most common cause of the narrowing in that descending colon or that rectosigmoid colon. Okay? Yes, you could have things like ulcerative colitis. Yes, you could have things like Crohn's causing all of these things, right? This does look kind of similar to that ulceration, which was that ulcerative colitis. It even looks kind of similar to the string sign with the Crohn's, right? So those are risk factors, yes. That could be what's going on. Guess what colon cancer is not going to have a lot of, at least in comparison? Diarrhea won't be as prevalent. Could you have diarrhea? Yeah, because what's happening here is that the stool can't get through. So the body's going to soften that stool to try to get it through here, and then when you come out, you're having diarrhea. Or really what some of that descriptor is going to be like string-like bowel movements. It's almost like, hey, I go to the bathroom and it comes out like a long pencil, right? Because what happens is it's making the stool as big as it needs to be to get through that area, and then it just comes out like a long pencil. That'll be a sign, you'll kind of learn that in GI, kind of like a sign to go, oh, we need to take a look at that a little bit, because that's not normal. If it happened yesterday, okay, no big deal, but if that's been the norm for the past, say a week or 2 weeks or whatever, that's concerning me about a structural abnormality, because why is your stool so thin and so soft? The body's trying to get it out, and that's the only way it can. So yes, the differential is wide with all these things. Ulcerative colitis, Crohn, family history of cancer, these are all risk factors of getting cancers too. So like your Crohn's and UC can lead to a colonic carcinoma. But what are we going to look at? Biggest thing I want you to focus on is the apple core lesion, and it's the most common cause of large bowel obstruction for this course. Apple core lesion and the most common cause of large bowel obstruction. Apple core lesion. Now wait a minute, that's in the same area as the string sign. Tricked me, because it's on the lower right area. But look at the rest of the image. That's large bowel. That's large bowel. Your string sign is in your small bowel, your terminal ileum. This is ascending colon. Yes, most commonly the cancers are in the descending colon and the rectosigmoid colon, but that does not rule out ascending colon as a possibility for your colon cancer. And look at the difference. It's a little bit thicker, and it literally looks like you just got done eating an apple and you just placed it in the patient, right? This is good. That's why they call it an apple core lesion. That is your concern for colon cancer. Cancer until proven otherwise. Diverticulosis. Let's talk about that. There's diverticulosis, which is the nature of having these outpouchings, and that's what they are. Diverticuli are what these outpouches are called. Now, pay attention to some of this because these are outpouches. You see how they're on the outside of the intestine, right? My white dotted arrow, my black arrow, they're on the outside of the intestine. There's one here, my solid white arrow that looks like it's kind of on the inside, but the other ones are all outpouchings. We'll take a look at what the inside ones look like in just a second. The polyps is what they're called, but these are diverticuli. These are my outpouchings, okay? And so this is on, and this is kind of what it looks like from an actual scope. You get the intestinal walls, and they just get these little outpouches. Most of the time, it's asymptomatic, right? These patients walk around with this. This is not anything you do with this just by having them. So what will happen is you'll find them incidentally. You'll be ordering a scan for something else, looking for something else. You'll find diverticuli. You then diagnose the patient with diverticulosis, which is the word for having diverticuli. Okay? It's not until they get inflamed and angry and start bleeding that it's diverticulitis, inflammation of the diverticuli. You can walk around with these bad boys for years and it does not matter, right? Does not matter. But when they get inflamed and angry, it needs to be treated. This stuff is painful. Painful, right? It is the most common cause of massive lower GI bleed because they get inflamed, they bleed. It's right near the rectum area. You're going to have your bright red blood, or people are like, yeah, I have a lot of bright red blood in my stool. What's going on? You having abdominal pain as well? Yes, I am. Okay, so you can think about that a little bit. Diverticulitis. The nice part about this one, for a lot of you, is you probably won't be the first ones to diagnose it. You might be, right? But you're going to get patients that are going to come in, and here's the CT that kind of shows you what happens when it's all inflamed and angry. That's what the big white circle is. See the thickened mucosal folds, the contrast. But you're going to get patients that are going to come in, and they're going to tell you, I'm having a flare-up of my diverticulitis. Now, most of the stuff we talked about, we're like, you need to order imaging, diagnose it, confirm it. If it's in their medical chart, and they have diverticulitis, and like they've been diagnosed with it, and they've been proven with it, these guys know what, these patients know what it feels like. And they come in and are like, listen, it's been a few months, like, I can feel it. I ate stuff I shouldn't have, it's flaring up, I'm starting to have the pain. Just treat them. Don't scan them again, just treat them. You'll learn the treatment in GI, right? It's like an antibiotic regimen. Just treat them. Because it's one of those few things that they know what it feels like. And we're not going to put them through a CT scanner every time they have an episode of diverticulitis. That is a lot of radiation over their lifetime. But if they haven't been diagnosed with it yet and you're trying to diagnose it, CT with contrast is your study of choice. CT with contrast is your study of choice because it gives that detail and it will help us break down between osis and itis. So that way we can appropriately chart that on there. If they have a history of diverticulosis and they're coming in for the first time with pain, don't just treat them. We need to confirm it's diverticulitis first because they haven't had a flare-up yet. So they don't know what that pain is and it could be anything else, right? So what does it look like? The osis is asymptomatic 85% of patients, but when it does flare up and it becomes itis, your colicky abdominal pain, right, gets better after I have a bowel movement, hurts more after I eat. Why is that? Because when we eat, the hormones tell the body, hey, start making room. So the bowel starts squeezing and moving. Those diverticuli are already inflamed and angry. It hurts. So that's why it gets worse with eating. Bloating, constipation. Usually left lower abdominal pain because it's usually that descending or rectosigmoid colon that has the issue. All right. And you'll see those outpouchings on either colonoscopy or CT, like I said, often an incidental finding. We find them by accident. That makes it osis. When they flare up and they cause pain, that makes it itis. And that's right over here. Symptoms: anorexia, nausea, vomiting, chills, diarrhea. Well, it's like everything else we talked about. But where is it at? What's going on? What's the patient history? Okay? Or more importantly, when I have these symptoms, what am I ordering this book for it? CT with contrast. CT with contrast. Okay? If a patient has a history of diverticulitis and, let's see, hold on this one. If a patient has a history of diverticulitis and they're due for like a colonoscopy or something like that, like you want to verify, never, ever, ever have a patient do a colonoscopy when they're having a flare of diverticulitis. Significantly increases their risk of perforation because it's already weakened, inflamed, and angry. You've got to wait until that goes away. Right? So if you have a patient with this and they're scheduled for a colonoscopy, you just got to make sure you counsel them when you give them that order. Hey, you got to get your colonoscopy done. But hey, I know you have a history of diverticulitis. If you have a flare-up, reschedule. Do not go get this done when you're having a flare-up because you risk perforation. And you'll learn that more in GI. But there it is again, CT with contrast. And so what are we seeing here? So we already know they have diverticuli, and we're seeing that fat stranding that we talked about. Look at it compared to the other stuff next to it, right? It's a lot lighter. I got the fat stranding from the inflammation, and then here is my thickened bowel, okay? And then I got these little air out pouches, right? These little dots along the edge. These are my out pouches. that are showing, and all these little kind of guys, like around the outside, these are my out pouches that are my diverticuli. And then how do I know they're inflamed and angry? I got all that fat stranding sitting right in here, right up against that organ area that is inflamed and angry. Notice I have nothing over on this area, right? No fat stranding over here. It's nice and dark and radiolucent. But when I go up into the area that's affected, look at how much lighter it gets, right? That's my fat stranding. Sure, there's a little vessel right there. Kind of matches up with these vessels here. Yes, there's a little vessel like right there. Matches up with these vessels kind of here. It looks the same. But all around this is just like that hazy, more radial opaque area next to an inflamed bowel spot. Diverticula are normal. When they get inflamed, they become diverticulitis. All right, appendicitis. Right lower quadrant. Right? Starts off periumbilical pain, then goes down to the right lower quadrant. So here's the appendix right here. This thickened guy, this little thickened loop here. That's my appendix. The catch with the appendix, right? Look up here in the picture. No, this guy doesn't have 6 appendices, right? These are all the different positions the appendix could be in, which means the pain can be referred to just about anywhere, right? It can be in the back. It can be in the front. It can be right in the right lower quadrant. It can be on the side. It can be up, right? It just depends on how their appendix is lying of where that pain is going to be when they have the appendicitis. CT or ultrasound is your modality of choice. Well, great. Which one are you going to pick if it's a question on the test? What's my patient demographic? Are they pregnant or a child? If they are, we're doing ultrasound. Is it any of us in this room who's not pregnant? Because I don't know the status of everybody. But if you're not pregnant, you're sitting in this room, you're getting a CT. If it's child or pregnant female, and you're evaluating for appendicitis, it is an ultrasound. So yes, both of these are highlighted blue as study of choice because technically they both are, depending on your patient demographics. And that goes back to a block 1 kind of foundational thing of if we have a non-radiological modality for kids or pregnant women that can get us the answer, that is what we use. Because we don't want to risk them. Okay. Know your demographics. You can use MRI, right? It says kind of when and why. The aspect between that would be if, because you need to do the CT with contrast, right? I can't give contrast. If maybe, let's say, can't get the contrast, so I do the ultrasound. The ultrasound is inconclusive, and I absolutely cannot do a CT with contrast for whatever reason. Like it's not an option. Either I don't have a CT scanner, or a CT scanner is down, or I don't have the contrast, or they're allergic to the contrast. Then we can do an MRI in those cases because it's better than nothing. But again, I would say have the surgeons kind of come down and take a look at it, let them make that call if they need an MRI or not, because if this is a true appendicitis, they need to go in and get it removed, right? And we don't want to wait an hour or two for the MRI tech to get in, and then we got to wait 45 minutes to an hour and a half for the MRI to be done because that's how long they take. They could already be up in surgery. So let the surgery team make the call on if they want an MRI before they're going to go and do this, because appendicitis is usually diagnosed clinically. This is just confirmatory. Right? But CT or ultrasound is your study of choice depending on patient demographics. Polyps. I am not going to test you specifically on polyps, but it's important because if you have polyps on a colonoscopy report, it's going to increase your risk of colon cancer, right? So it just kind of gives you an idea of the size and what's going on there and what studies you can do to look at it. And I don't want it to be the first time you see it. And this is what it looks like. Similar to the diverticuli, but it's on the inside of the colon. So I show it to you to help you distinguish the diverticuli from the polyps because they'll look kind of similar, but polyps are going to have a lot of times a little bit of a stalk. Sometimes they'll have a sessile one like right here, but it's more of a filling defect, right? So I got my contrast that comes in, a little bit of air, and then I got like this like round kind of goomba sitting in there. And that shouldn't be there. So I'm concerned what that is. This patient You're not going to be able to diagnose for sure that's a sessile polyp. They bought themselves a colonoscopy to actually get a camera looking at it to figure out what's going on. And the nice part about the colonoscopies, when they see these guys, they just take them right out and then send them off to the lab pathology to figure out what it's actually made of, what risks they're going to have for their colon cancers. But you can see how the pouching kind of looks similar to the diverticuli. The difference is it's on the inside, not on the outside. So that's why I have these in here. Outside diverticuli, inside polyps. Okay. What's going on the left? Small bowel involvement, good. Based off of just the picture, can you tell me obstruction ileus, generalized ileus, anything? Yeah, probably not. I'll tell you it's an obstruction because I chose the picture. But you're right, I need to give you patient history, patient physical exam with just this picture. Because this could be one of those adynamic or generalized ileuses, right? The localized ones were just a couple of loops, but this could be the whole thing. I don't know. I want more information. So good. What's going on the right picture? So if we were to guess a diagnosis on the right picture, yeah. What bowel is affected? Large bowel. Good. So there's a large bowel obstruction. Okay. We don't have a whole lot of large bowel ileuses. Ileus is typically a small bowel thing. But large bowel obstruction, and you can tell by the way that the bowel looks. Looking for the haustra, look at the difference of these two together. I like this slide for you guys because it really breaks down that small bowel versus the large bowel and how they look, right? Because every once in a while you're going to be like, is that a valvular cone? Is it kind of comes all the way across? Look at how many I have on here, right? It's not going to have just one, right? So don't trick yourself into going, oh, there's one across, so that must be small bowel. You should have many, okay? Like this picture kind of shows. So this is a good slide to help you distinguish between the two and help you kind of get an idea of what they kind of look like. Because again, they're both in the same area, diffusely across the abdomen. Anatomy pictures is not helpful in this case, right? But understanding the anatomy of what we should see is what kind of helps you distinguish between the two. If you had to pick an abnormality on this guy, what would it be? Ulcerations. I like that. Right? Kind of got that polka dotted feel, right? Yeah, is that string sign? Well, this is large intestine, so not string sign. And if you look closely, I have one edge here and one edge here, so it's not super, super thin. And then I got all my little kind of like polka dots taken out on all these guys here. So one edge here. So yes, these would be ulcerations of the transverse colon, probably a little bit of the descending as well, right? Maybe a little bit of both of the ascending as well, but primarily in that transverse colon. Yes, sir?
Sir, with the polyps versus diverticulitis,
Yeah.
with it being an X-ray and everything being like super close, how can you tell that it's not just on the back of the valve sticking out, it's like actually inside?
Because on an X-ray, right, if that was on the back, I probably wouldn't be able to see this kind of coming down and into the lumen, right? If it was sticking out, it would be sticking out posteriorly. And really what I would maybe see is just this part, just like right here, sitting in there, right? So then what would I say on that? Well, that would probably be a colonoscopy anyway, so we'll get a good look at it and kind of see what's going on. And then that colonoscopy, as we saw in the picture before, will show outpouching if that's what it is too, because we'll see all those extra little holes kind of doing the outpouching. Yeah, good question. All right. Let's take a 10-minute break, and then we'll come back and we'll talk about the spleen. Everybody loves the spleen. All right. There it is. The spleen. It's a good looking spleen, yeah. Right? Doing his job, keeping us healthy. Great stuff. Great stuff. All right. Normal study. What the heck is this? It's one slice of a CT. That's the spleen. Right there. Right, that's kidney. Kidney, just by to say, hey, look, it's that little pouch you guys do when you do your fast exams. Right in there. See how they hug? They're friends. All right, so there's your spleen. All right, normal study, CT of the spleen. Abnormal. Right? Know what abnormal is. The biggest thing with the spleen is understand when you have splenomegaly. okay? Should not project beyond the 12th rib on x-ray. That's number one, okay? Number two, if the gastric bubble is pushed across midline, or if you're missing that bowel gas pattern in that area that we talked about when we looked at the x-rays, that's your sign that it's an enlarged spleen. Here's my 12th rib. Definitely enlarged. Here's my 12th rib. Again, look at my 12th rib for my liver. Oh look, it projects down. Liver is supposed to, spleen is not. Okay? We kind of already covered the causes of an enlarged spleen, right? Most commonly mono, it's a big one. And don't let them do contact sports. In the notes, if you want to know more, not for the test, but if you just want to know more, you'll learn it more in GI. There are all kinds of causes of an enlarged spleen. We got it listed by bacterial, by viral. I think there's even some fungal ones in there. Hematological blood disorders like sickle cell. So if you're just curious what that differential is for an enlarged spleen, it's pretty massive. And then you would have to do the workup to figure out what's going on. Viral with mono is usually one of the more common ones that we see, but enlarged spleen, know how to find it. Okay, here's the x-ray again. The arrows are showing you how it's projected down past the 12th rib. I can make that out. I got my direct visualization because this patient is thin enough to be able to actually see the outline of the spleen and trace it all the way around. But then I also have my indirect, if I didn't, to where it's shoving all this bowel gas down. I have no bowel gas in that upper quadrant area, right? I can even see the liver really nicely on this one too. So this is a really nice thin patient where you can actually make out those organs to notice the splenomegaly. The CT here, this is CT with contrast. Okay. This is a ruptured spleen. What you're seeing is contrast going into the spleen and then blood around the outside of it. So the darker, kind of more radiolucent gray area is just regular blood, because it's not going to have as much contrast as inside the spleen, because all the vessels are bringing the contrast to the spleen, and we're having just a little bit of leakage. So think about it, if you were, I guess a good way to describe the densities of the contrast and stuff, if you were to use like that, like the crystal white or whatever in your bottles of water, and it's that nice kind of dark color. If you take just a little bit out and you kind of spread it out in like a plastic Tupperware, it looks lighter than what's condensed in your bottle. That's kind of what's happening here. Yes, it's with contrast, but it's all kind of condensed within the spleen, and then as it's leaking out from the rupture that they have in there, you're getting the blood. It's not as bright. It is more radiolucent because there's not as much contrast compacted into that blood, and it's kind of spilling out. Right, that's kind of the dime explanation, 10-cent explanation of why there's a slight different density in that blood surrounding the spleen. That's it for the spleen. Know how to find out it's large, right? Know where it's at. Know the anatomy. Please know where it's at. Like, not what's a spleen. At least know where it's at. Like for my test, if you don't know what it is, you're going to be okay. But you got to know where it is, and you got to know whether or not it's big. Liver, other side. Liver. Okay, I like this one because it kind of breaks down different areas of the colon and everything else on there. So, is this fat stranding? No, this is mesentery. Right, these are all the vessels that are kind of coming back. And then when I look, my fat stranding would be normally attached to or right next to the organ that's inflamed and angry, and right next to my bowel and all those organs, like I'm good. There's mostly radiolucent areas, we're okay, right? But here's my liver, portal vein, pancreas we'll get to later. Look how small the spleen is. It's not really that small, that's just a slice. The spleen's gonna be a little bit more posterior, right? But there's my liver. It can project past the 12th rib. That is normal, you should see that. That is abnormal. Look at the contrast on the liver here. This is a CT with contrast. You can see the different kind of bright spots, more radiolucent areas. Here's my gallbladder, so you can see the difference. These would look the same if I didn't give contrast. Okay, gallbladder look the same. You can see all the contrast going through, and the vessel's kind of nice and it's uniform. You know, it kind of looks the same. And then you get something like this. Then you get something like this. First of all, I'm projecting over into the other side. That's a problem, right? That's all liver. Okay. What is going on all up in here? No idea. I'm thinking potential cancer, right, or tumors or something, because it's a mottled appearance. It's kind of within the main liver. Biggest thing what I need you guys to know for this, and what we covered is, that's an enlarged liver. That's hepatomegaly. It should not be that big. That's it. Know where the liver's at. Know if it's enlarged. Yes, sir. So the liver, for the most part, I mean, it kind of ends kind of right at midline. It's not necessarily like if it crosses midline, it's abnormal, right? It's just more of a, well, it shouldn't be all the way to the other side, right? And then for the enlarged liver, you can kind of see, here's where your pelvis is coming up on this one picture, right? So if it dips down into that ileum, that's considered enlarged. You should be, the technical, there's not like a technical measure of it. If it's this far past the 12th rib, it's considered enlarged. It's more of a generalized kind of diagnosis, right? So it should project slightly past the 12th rib, should not be profusely past the 12th rib, and especially if it's down into and being projected into the pelvic area, that's hepatomegaly. If it's coming all the way across, that's an enlarged liver. But there's not like this size or anything like that, because every patient's liver is a different size, so it's kind of hard to just put a size on it. You're not wrong. But that's it. That's all you need to know about the liver. Gallbladder. Ultrasound is a study of choice. We have been doing a lot of CTs. Don't get excited just because it says CT with contrast and think it's the right answer. Figure out what we're asking here and what's going on, because there are a couple of ultrasounds in here. The appendix for those pregnant patient pediatrics, the gallbladder is your study of choice. Okay, nice. Filled with bile or fluid, usually bile, can't really see much, nice and dark. Posterior acoustic enhancement because of the fluid-filled structure, okay. Posterior acoustic shadowing, when I have a stone in the gallbladder, got that hyperechoic stone sitting in the gallbladder causing posterior acoustic shadowing. Also known as cholelithiasis, right? That positive Murphy sign could be either due to cholecystitis or cholecystitis being caused by the cholelithiasis, right? So cholelithiasis is just having a stone. Having a stone in there is not necessarily a big deal unless the gallbladder is inflamed in cholecystitis and is causing pain and symptoms and issues, okay? This is one of those situations where I don't see a stone, but I have this extra kind of hyperechoic kind of mess sitting in here. What this is this says right there, sludge. This is from your patients who have chronic cholecystitis. A lot of times that bile can kind of thicken and cause, and just what's called sludge. It just kind of sits in there and it can inflame the gallbladder. Does this warrant a gallbladder removal? It's kind of a trick question, right? It depends. How symptomatic is the patient? How often are they having attacks of cholecystitis? How often are they having to be treated for it? I can't remember the cutoff, but GI people, like GI has like a cutoff of like, it's kind of like your tonsils, like X number of episodes within a year warrants, we're just going to remove the gallbladder because you're coming in so often for the symptoms. It's just financially better and just medically better for us just to remove it. You'll probably learn that in GI, but I want to say it's like 3 or 4 times a year. I can't remember exactly what it is. But sludge can cause that. So it's not quite a stone, right? And what's funny about it is we still have that posterior acoustic enhancement behind it, right? Why? Because all this really is like a thicker fluid. It's just a more thick fluid. So it projects up some of those sound waves, and you can kind of see it here, how it's like I have the enhancement, but then there's like this like regular area sitting like right behind the sludge here. It's because some of those sound waves are projecting up, which is what's showing you the sludge. But really, it's not a solid structure. That would be an abnormal study too. That's it. Ultrasound, gallbladder, stone, maybe a little bit of sludge. Those are abnormalities. That's all I need you guys to know. Study of choice is the ultrasound. Know what that patient looks like. Know the positive Murphy sign. know the terms cholecystitis or cholelithiasis and things along those lines. So that way you can understand right upper quadrant pain, right? Those kinds of things lead to a gallbladder concern. So then we can order the ultrasound. Yes, sir.
So is that always going to be a rule thing that they can't just remove the stones?
They cannot, yeah, typically they're not going to remove, good question. So it's like, would they ever just go into the gallbladder and remove the stones? The answer is no. They will remove a stone from, if it's small enough to get into the biliary ducts in the biliary tree, they'll go in and do like that ERCP that we talked about, and they'll try to pull the stones out in that aspect. But if they're large enough to just be sitting in the gallbladder and not fall into the biliary tree, they don't go in and remove them out of there. Because there's just, the way they go in for the stones is like a small area, and they can get into the biliary tree. But to pull a stone that size out, there's nowhere to pull it out. They'd have to cut open, they just take the gallbladder out. Because you don't actually need your gallbladder. So if you have enough stones in there causing you pain and symptoms, we're just going to take it out. So it doesn't necessarily cause a fat intolerance. You're recommended to change your diet because you don't have as much bile to help break down the fatty foods. Plenty of people that don't, right? So it's not mandatory. You don't have to. It's more of a recommendation going, hey, you don't have to store, because you still create bile, right? When you don't have your gallbladder, you still create bile. The difference is it just automatically pours right into that duodenum, and it doesn't sit in a little storage area to squeeze when you eat a fatty food to need it. You're still creating it, because the liver is what creates the bile, and it just goes into the gallbladder, right? So you're still creating it, just don't have the storage unit. So you should limit your diet, but again, most patients don't. Pancreas. Pancreas is really hard to find. Have we pointed the pancreas out on almost any x-ray yet? Nope. Maybe one where it's like a really thin patient, it was a little inflamed, it was right there. It is dang near impossible to find on an x-ray. Which means you need a CT. So if you're trying to eat out the pancreas, CT. Now, this is one of the clearest pictures you will probably ever see of a pancreas on a CT. So don't get excited. It's not that easy to find. Somebody here tomorrow is going to try to find the pancreas on a CT. You won't know when, you won't know who, but somebody. So it's right here. It's this fluffy, kind of elongated organ that sits basically mid-epigastric region in the abdomen. Okay? That's your pancreas. Usually the head of the pancreas is more center, or sorry, the tail. The head comes into the duodenum. Did that backwards. But you can't see the duodenum here, so you can't actually fully see the head. Kind of spans out in here. Normal pancreas should just look like, the best way for me to describe it, should just look like a kitchen sponge on its side. Just a nice little sponge, kind of set in the abdomen, sitting on its side, all right, and it's just been kind of sitting there in the center. When we have abnormal ones, this is what we're going to start to see. So pancreatitis. Here's my pancreas. Looks a lot different than what we just looked at. Look at all my fat stranding around that pancreas. Right? And go back. Look how clean and neat my visceral fat is. Right? Look how clean and neat all of the intra-abdominal fat is. Nice and radiolucent. This is a happy pancreas. This is not a happy pancreas. Look at all my fat stranding. Look at all the anger we have going on in here. All around this. This is an episode of pancreatitis. It's a clinical diagnosis. You do not need imaging to confirm this. Okay? You'll learn how to diagnose that in GI specifically. You don't need it. But if you don't know it's pancreatitis, it's kind of like diverticulitis, right? If you don't know that, and this patient never had it before, you're going to need the CT as a study of choice to confirm it. But once they've had it, patients know what this feels like. Yeah? So the pancreas is right here, and then the fat stranding is all of this right around it. Okay? And so let's go back, right? Because I know it's hard to see. So when I go back to my normal, right, it's in a different area, but really what I want you to focus on is the pancreas here, and look at my visceral and intra-abdominal fat all around it, right? More radiolucent, clean, neat. I can see that edge of the pancreas. I can see where the fat kind of starts. It's happy. Everything's going good. Then when I go in here, I got my pancreas here. I know it doesn't quite look the same, but look at around it. This is not happy, dark, more radiolucent intra-abdominal fat kind of laying around there. It's more light, it's more gray, it's more radio opaque, kind of just the lines are stranding. All right. The one down here is chronic pancreatitis. The pancreas is starting to calcify. This is those amorphous calcifications that we talked about, which would be abnormal on an x-ray. You might be able to pull out the pancreas on this x-ray because of all the calcifications we have within this pancreas. And now I'm more concerned about whether or not they're going to develop, or this is pancreatic cancer, or going to become that. Right? We have chronic pancreatitis that is turning into these calcifications and forming all what looks like, these are not necessarily pancreatic stones. We don't have pancreatic stones. These are the glands of the pancreas starting to calcify. Maybe on x-ray you'll see it, but in reality CT is what's going to stand that out. Here's another abnormal pancreas, right? Like, well, how do I know it's abnormal? Again, look how clean my normal pancreas is. Clean, beautiful, pretty, little kitchen sponge just laying on the side. Calcifications here, big old Goomba with calcification here, and I say Goomba because I don't know what it is. I don't know yet. I just know it's not supposed to be there, right? Calcifications here, and big old mass and Goomba kind of sitting there with some calcifications. This is another episode of chronic pancreatitis, and my question becomes, is this the start of a tumor? I don't know yet. There's going to need to be further testing, further studies, further everything, but this is an abnormal pancreas. Filling defect. This is with contrast, right? The yellow circle, everything's happy. Why do I have this radiolucent thing in my pancreas region? Possibly a tumor. It is, just because I found a tumor one. But you don't know just from the image, right? The point I'm getting at is know what a normal pancreas looks like. So when you see it on CT and it's not normal, you know you need to do further workup. You don't miss it. Not making you pull out pancreatic tumors, not making you determine if it's a cyst, not making you determine any of that. I need you to know that CT is a study of choice to evaluate the pancreas. And know on CT kind of what a normal one looks like. So if you see something abnormal, you know it's abnormal. Right? Okay, some quick review slides here. We'll do the other stuff before we go into the GU stuff. What do we have going on here? Splenomegaly. Good. Just gonna move on then. What are these? Gallstones. How did I know it's gallstones just from this picture? Well, we didn't talk about a whole lot of ultrasound imaging, did we? Gallbladder, posterior acoustic shadowing. Gallbladder, hyperechoic lesions, posterior acoustic shadowing. Gallstones. Good job. Okay. What is going on the left side? Polyps. Good. Inside the lumen. And then on the right one, diverticuli. Not itis. Diverticuli is the anatomy. Diverticulosis is the diagnosis, unless they're symptomatic. Once they're symptomatic, it becomes the itis. Asymptomatic is the osis. Questions on GI stuff? Okay. Let's go into everybody's favorite GU. There's not much left in the GU. Urinary tract, male pelvic, female pelvic organs. Boy, this feels like the what category when it comes to imaging? Ultrasound, except for in some cases. But that's good. You know it's ultrasound except for in some cases, know the some cases, and then you'll know the rest is ultrasound. All right. The urinary tract includes the kidneys, right? Even though they're up here, they're not part of the GI tract, they are part of the urinary tract. So remember that. So we're going to go over kidneys, ureter, bladder, urethra, and that's about it. So that's why this part kind of goes quicker towards the end, because it's like, here's a couple slides. No, it's a CT. No, it's an ultrasound. Moving on. Okay. IVP. is an old school way of looking for kidney stones, the ureters, the bladder, that kind of thing. Now it says this exam has largely been replaced by CT urography. That is correct. Why do I teach you an IVP? Because you might be deployed in a setting that doesn't have a CT scanner. So then this is still what you do. The only time you're doing this is when you don't have a CT scanner, okay? What the goal of this is they inject contrast intravenously, okay? And then very similar to that small bowel follow-through, they're taking multiple x-rays. What they're trying to do is catch the contrast in the renal calyces and then catch the contrast flowing down the ureters into the bladder. Because if you have a stone in the ureter, you will have a blockage of that contrast flowing. If you have a stone that is causing hydronephrosis or swelling of the calyces in the kidney, you will have larger renal pelvis, and you'll be able to see that. So that's why they're doing this, is to look for stones and really look for any kind of damage here. Now this is the most perfect picture you will ever see on an IVP, because I can see the ureters from the kidney almost all the way down to the bladder. I can trace the whole thing. That is rare, because the ureters do what? They move, they're tortuous, right? So this is going to be another one of those things to where you combine multiple x-rays to see the whole ureter. So they'll try different ones. Sometimes they'll rotate the patient up to the side, 45-degree side, to try to move them a little bit, to try to get the ureters in profile until they can see contrast through every section of the ureter, and you piece it together like a little puzzle. And as long as you can see that, you're like, okay, I don't have an obstructing stone. You can have a non-obstructing stone sometimes, but there's not one obstructing, because I have contrast going down both sides and into the bladder. So again, this is, you will do these and order these if you don't have a CT scanner looking for kidney stones. Okay, so let's talk about kidney stones and urinary stones. So we do not give contrast when we do our CT when we are looking for kidney stones. Why? Right on the slides. The stones are white. If I load these patients up with contrast and I do a CT, I can't tell you where the stone is. Because again, it's IV contrast, right? So it's going to flow into the kidney. It's going to go into the ureters. It's going to go into the bladder, just like this x-ray did. If I have bright ureters, I have no idea where that stone is at, because it's going to look the same. So this is one of the very few that we talked about to where a CT non-con, CT without contrast, is your study of choice for kidney stones, okay? Here we show stones within the kidneys. We're not overly concerned about those as long as they don't get into the ureters or cause any pain. Here you have a stone in your right ureter. And here you got it kind of down in that junction almost where it's going to go into the bladder. And I got kidney stones and ureter stones. I can have both. What's going on in the aorta? Calcifications. It is not stones in the aorta. That is the start of calcifications for this patient with their aorta. Correct. We're not going to die. I mean, everybody's going to die. We're all dying, but not at this stage. Okay. Here is an example of what can happen when you have an obstructing stone and the difference. Not only do I have your normal study over here, but I want you to focus on the normal study first. Follow this ureter down on the right kidney. See that gap there I talked about? That's not necessarily because there's an issue there. It's just on this picture, either the ureter is peristalsing a little bit, or they're just positioned in a way to where there's too much subcutaneous tissue or visceral fat kind of hiding it. So they'll probably have to get another picture to shift them a little bit so you can see the contrast in that part of the ureter. Right? So that's kind of what I was talking about. Like a lot of times it looks like it, but in the actual study you will have multiple pictures to piece together when you're out in clinic. But if I see this, right? There's a blockage. Fluid is backing up. The contrast is backing up. It's not flowing down at all. I don't see any spilling out of the kidney at all on this one. See a little bit here, right? And again, I'll have other images that will show me, but my first instinct when I see this here is I'm like, okay, this pelvis and calyce, they are dilated, more so compared to the other side. And it's another one of the things I love about the IVPs and the CT scans is you get both of them together. So you can compare one to another. Very rarely do you end up having bilateral hydronephrosis or bilateral kidney stones, that kind of thing. You can. It doesn't happen super often. But that's your sign of abnormality there. Okay. Here's an ultrasound. normal kidney, right? Kind of like that fast exam we looked at, the normal kidney. You see the pelvis and the calyces. Look at all this extra fluid I have where the kidney's at, right? I can see hydronephrosis on ultrasound. I can see that. So now, why would I do an ultrasound? Let me see if I have it in here. I don't. So, yeah, sure, maybe the EFAST exam, right? But then I'm not really looking for the kidney type stuff like the hydronephrosis. I'm going to do an ultrasound on a patient that has recurrent kidney stones. Okay? Why? How much radiation is a CT scan? A lot, right? And so if they're getting a CT scan every time they have a kidney stone, that is a lot of CT scans. What's my primary concern with the kidney stones? Is it obstructing or not? That's what I care about. Because when they do the CT scan, when they first find it, they're going to measure it out and be like, okay, it's 5 millimeters or less, so it's going to pass just fine, or it's larger, you got to have, you know, a special procedure or surgery to get it removed because it won't pass. I care about if it's obstructing, especially with my chronic kidney stone patients, right? If it's obstructing, I can do an ultrasound of the kidney and figure out if I have hydronephrosis or not, because if it's obstructing, it's going to cause hydronephrosis because I'm losing it back up. So in my patients that have recurrent kidney stones over and over and over again, they, you know, oh, I get a kidney stone, you know, 4 or 5 times a year or something along those lines. Just ballparking it. Recurrent kidney stones, ultrasound is the preferred study because all I'm looking for is hydronephrosis. I'm looking to see if it's obstructing or not. Because if it's not obstructing, here's your Flomax, here's your pain meds, it'll pass. And now I didn't have to give radiation to treat the patient. If it is obstructing, now we're going to have to get better imaging, figure out where it's at, so that way they can go ahead and probably get a surgery to get it removed. Or do like, they have like an ultrasound, not this kind of ultrasound, but they have a specialized, more powerful ultrasound, I forget what it's called, to where like they put sound waves in and it breaks the stone up, and now instead of one big stone, you have like 9 small stones, so you apologize to the patient because it's going to suck to pass 9 stones. But they need that kind of a procedure if it is obstructing. So recurrent kidney stones, ultrasound. Acute kidney stone concern, CT without contrast. Okay. Here's just showing you the stepwise process. You don't have to grade the hydronephrosis, it's an FYI slide, but it's just kind of showing you how it kind of continues to get worse and worse and worse and worse, and how it can stand out on those ultrasound images. Right, that excess fluid within the renal calyces that is not, I'm going back a slide, that is not necessarily visible on my normal kidney. Okay, so you don't need to know the grading, just kind of showing you how it continues to get worse. We didn't cover it, but what do we think is going on here? Kind of covered it. Could be a bunch of cysts, right? See all these little fluid-filled pouches? Could be a bunch of cysts. Could just be run-of-the-mill hydronephrosis. I know there's more fluid in the kidney than there's supposed to be. Good. You guys got it. There's my normal kidney. For those on this side of the class who can't see it, this is an FYI slide. It's hidden by this fun little warning that some indicator is bad. So I don't need you to necessarily memorize all the causes of hydronephrosis for this class. But if you end up having hydronephrosis that doesn't have kidney stones, you need a further workup because something's going on. Okay. So this is for your reading pleasure over the break, I guess. All right. So here are some more images. Got my normal over here. Got my abnormal. This weird tortuous ureter here. See how that comes down, this weird tortuous ureter. But look, I'm getting the back up. I'm getting some hydronephrosis there. Okay, I got the deviated ureter. There's actually, in this one, I made a note on it here, there's actually, you can't see it, right? This is the concern with contrast in some of these things. You actually have a renal pelvis calculus in here. You can't see it because of the contrast. But if you were to do the CT without con, you would see that there is a renal pelvis calculus in here as well, which is causing some of the pressure and causing the tortuous kind of ureter. But this is the dangers of doing it if you did it with contrast. I don't know if that's a calculus or not. That's just showing you the urinal junction where it's kind of coming in here, where it comes into the bladder. So what the key is with this, right? So, and thank you for, if I'm in a clinic and I'm looking like, is there an obstruction or not? I got a backup, is there? Well, look, I go all the way down and I even have some coming into the bladder here. So even if there is some kind of pressure or stone, it's not fully obstructing because I have contrast coming into the bladder. And that's kind of what that was showing there. Bladder studies. So this is still just x-rays as part of that IVP. We look at the bladder too because we want to see if the bladder fills with contrast. You can kind of see here that it's, after they went to the bathroom, you can still see contrast spilling in from the ureters. So we definitely have that. It spills in posteriorly, so it looks like it's just posterior bladder area. But then when we get a filling defect, like look at my normal, I should have just contrast all up in here. And why do I have this weird area there? Right? I don't know. Bladder cancer until proven otherwise. So they're going to get something called a cystoscope, which I think we'll talk about here in a little bit, to actually go in there and look, and they'll see is there cancer or not, and take it out potentially. Right? You are concerned for bladder cancer anytime anybody has painless hematuria. Right? Painless, because kidney stones hurt. Kidney stones are going to cause hematuria, right? Urinal stones cause hematuria, but it's painful, right? Any patient that has painless hematuria, and you just find it incidentally, annual well visit, you order your urinalysis, or you're looking for something else, and you order the urinalysis just because it's the right thing to do, and you just want to make sure everything's okay, and there's blood in the urine, but they've had zero symptoms, no issues, just no dysuria, no changes in frequency or flow or anything, but there's blood in the urine, they need to be evaluated for bladder cancer. Right? It's something that is commonly missed because the patients don't come in because they're not symptomatic. Because bladder cancer does not cause a whole lot of symptoms. So. Urethral imaging. So now we did the barium enema. Same concept of the urethra. Male or female, tube goes in, balloon blows up, we retrograde and put contrast in through the urethra to backflow it into the bladder. So what you're seeing here is we have a little fistula because it's backflowing into the prostate a little bit, and we have the stricture supposed to be going into the bladder up here, but here's my normal, nice open urethra. Here's my normal, nice open all the way through. And then here I got this stricture kind of sitting right here and a little bit of black flow into the prostate. So my normal exam is this. When I'm mostly concerned about urethral injuries, usually along with pelvic fractures or pelvic injuries like we talked about last block a little bit. Filling defect in your bladder could indicate what? Cancer. Could be a stone, could be a stricture, but cancer is what I want you to think of first and foremost. This is another normal IVP study. Normal IVP study. Remember this slide? Still plays. Okay? Let's go over it one more time real quick. Pelvic fracture, pelvic trauma, x-ray is your initial study. Your study of choice, if they're stable, is a CT. If they're unstable, it's a fast exam. Right? Okay. Cystogram, specific study of the bladder. Right? 70% of bladder ruptures occur with pelvic fracture. So if you're concerned that, let's say, for example, you do your fast exam and maybe you do see some fluid in the bladder area, you're like, hey, this is positive, we're not sure where it's coming from. You could do a cystogram, which is basically just filling the bladder with contrast, the same way we just did the urethrogram, right? But we're going to do it and watch the bladder and look, and all the contrast should be within the bladder. When we see contrast filling out, that's indicative of a bladder rupture. The procedure is the same as the urethrogram. I'm just taking the pictures at a different time. I'm waiting till the bladder fills with the contrast, and then I'm taking the picture, as opposed to taking the picture when the bladder is, when the contrast is in the urethra. So a cystogram is going to be your study to evaluate the bladder. Sometimes you're lucky with patients and you can get a picture of both with just one shot. That's that ascending or retrograde urethrogram we talked about. for urethral injuries. I can see my bladder, but I'm also evaluating the urethra, which definitely has a stricture, a narrowing right there. Okay? When do I get concerned for urethral injuries? Hematuria, sure. Blood at the urethral meatus, both male or female, especially if they're coming in the situation of trauma. If you're doing your visual inspection, your physical exam, blood at the urethral meatus. You're like, I think there's a urethral injury here. There's not very many things that are going to cause actual visible blood at the opening of the urethra. Be concerned about an injury there. This is a urethral transection. This was a pelvic fracture. You can see where they put the binding in surgery to try to bring the pubic symphysis back together. They're probably going to surgerize and fix that. I mean, they would have to. I don't know. I don't know if they got to walk around with a bag for the rest of their life. I don't know that answer, right? Outside of my area of expertise. But this is why we do those studies sometimes, because this is showing I did a urethrogram, nothing went into my bladder, and the contrast just stops. So this is a transection of the urethra, unfortunately. Okay, so urethrogram, cystogram, okay, CT without contrast for the kidney stones, IVP if you don't have a CT available to you, all right? Mostly concerned about obstructing versus non-obstructing. If they are recurrent kidney stones, ultrasound, not CT. Okay. Questions on that? Okay. Male pelvic organ. We have one. We're simple folk. Just one. Right? Your biggest concern is testicular torsion. Okay, you're going to learn about more in GU, but really it's that severe unilateral scrotal pain. They call it a thunderclap pain. Why? Because we're males and we're drama kings, right? We have that thunderclap headache. So like, ooh, thunderclap, that sounds scary and good. We'll call that thunderclap pain down there too. I say that in jest, like this is severely painful. Just like ovarian torsion would be on a female, it is severely painful. Because what you've basically done is that it's twisted upon itself and it's cut off the blood flow, right? It's the lack of blood flow that causes the pain to the testes or to the ovaries when we get to the ovarian torsion one. Nausea, vomiting, lower abdominal pain, right? Sometimes you can have chronic torsion, which sometimes it resolves on its own. Doesn't matter. If you got testicular pain like this and you're concerned about torsion, ultrasound with Doppler, because I care about the blood flow. I want to see blood flowing to and from that testicle, okay? Here's the kicker. If it screams torsion, and you think it's torsion, and it looks like torsion, and your ultrasound shows blood flow, but you're like, this is still treated like torsion, because 25% of torsion cases still show blood flow on Doppler ultrasound. It is not definitive. It is not 100% like, because there's blood flow, there is no torsion. It just means it's not completely torsed, right? So when you see on physical exam the things that look like torsion and the symptoms are like torsion and the ultrasound looks normal with blood flow throughout, right? Then I'm still going to treat it. Don't get hung up on the red and the blue on this. If you notice, it's a little bit different for this particular model. It's like yellow to dark red, right? But what you do see is blood flow coming into all areas of the testicle. I have only one small area of the testicle that has blood flow. There's your difference. I just have pretty much no blood flow to this entire testicle, but here I can see most of the vessels kind of splurging out and giving blood flow. That's all you're looking for. But again, if you get this, you get the normal, but it still screams torsion, still treat them like it's torsion, and same for the females when it comes to the ovaries.
Does that mean that we don't need the ultrasound to confirm? We can just quickly treat?
So you want to do the ultrasound. Good question. So for those who couldn't hear, the question was, does that mean we don't need the ultrasound to confirm? Can we just clinically treat? So the answer is no. Still get the ultrasound, because the difference in clinically treating this and potentially needing surgery to treat this that's the difference, right? Because you might be able to fix this torsion on your own, but you might not. And the timing needed to make a decision on the testicle or ovary without blood flow is much faster than the timing needed for the one that still has blood flow. So that's why we still need the ultrasound, because the ultrasound tells us timing. How much time do I have to fix this before I potentially have a dead testicle or a dead ovary? So still get the ultrasound. Because again, most of your cases won't have blood flow. Yes? Mm-hmm. Yeah, that's a good question, right? So the question was, if you manually fix it, do you have to do another ultrasound to confirm if there's blood flow again? You don't have to, because the symptoms should relieve from the patient, right? And you will see it's been manually fixed, everything looks the same, and you should be good to go. You'll probably maybe get them like a follow-up with you if you're the PCM to just follow up in a couple of days just to kind of make sure and give them very strict return precautions if the pain comes back. Right? If it looks like this the way it did when you come in, I need you to come back right away or go to the ER. So it's more kind of prepping them and kind of sending them out. Yeah. All right. That's it for the males. Testicles, torsion. Great. Females, first line. Study of choice is ultrasound. For every female pelvic organ. Yeah, MRI is becoming a little bit more increased, but in reality, it's ultrasound for every single female organ. That is my study of choice. These are the ones we're going to cover. Ovaries are the same concept as the testes. Doppler to look for blood flow, concerned mostly about torsion. This one kind of has the red and the blue ones where it kind of shows you, right? I have my normal here. And then I have one that has like these ovarian cysts, right? Ovarian cysts can be painful, but the ovaries naturally create cysts. So like, if I'm concerned if this is abnormal or not, what do I need to know? Where is she at in her cycle? Right? Because in the menstrual cycle, the way it releases an egg is the ovary creates a cyst with the egg in it, it bursts, the egg comes out, fallopian tubes grab it and flow in. So depending on the timing, ovarian cyst on ultrasound might actually be a normal finding. You guys don't need to worry about that too much right now, you'll get into that later, but just understand that timing is important when it does come to the female organ, especially the ovaries, because it may not be a concern. Now, if I have like 9 cysts in the ovary, that's not just ovulation. Right? We shouldn't have that. But just something to kind of keep in mind. Ovarian torsion, all the same stuff, right? We're going to do a Doppler ultrasound. It's the initial imaging and the modality of choice, okay? CT, abdomen, pelvis can be useful if your ultrasound is normal. So there's the difference between the males and the females. If your ultrasound is normal and you suspect ovarian torsion, you get a CT. Why can I do that for the male versus the female? I have a lot of other subcutaneous and visceral fat and all the stuff that can help absorb that radiation before it gets to the ovaries, to where it's a little bit safer than just putting testicles through a CT scanner, right? There's nothing to protect that area from all that radiation. At least I have a lot of abdominal structures that are going to absorb a lot of that, so it's a little bit safer. And ovarian torsion, I can't just manually fix, right? So if your ovary is torsed, they're going to need a surgery to fix it. So I really want to make sure that if it sounds like torsion, screams like torsion, I did my ultrasound because it's a female pelvic organ and it's normal, but I still think it's torsion, they're getting a CT because I need to verify that it's not torsed. Because I don't want to kill that ovary. Lots of blood flow into the ovary on the right side. Okay? Left side has almost no blood flow. I have blood flow kind of coming to it, but not inside of the main ovary. Right? Got the blood flow kind of coming to, but not on the inside. Plus something that looks like some kind of cyst or something right here, some kind of abnormality in the ovary. More importantly, I got no blood flow on the inside of the ovary. Doppler ultrasound. Hysterosalpingogram, or HSG. This is the only way to assess the uterus and the fallopian tubes. This is an x-ray. This is not an ultrasound. This is a few of those nuances. This is an x-ray, not an ultrasound. What they do is just like the urethrogram, same concept, it's retrograde. They put the catheter up into the cervix, they blow up a little balloon, blocks it off, fill it with an ionized contrast to watch the uterus fill and watch the fallopian tubes fill and spill out into the intra-abdominal area. This is your normal, this is your abnormal. Notice my fallopian tube on the left side does not fill up. There's a blockage there. Could it be just closed on itself? It could be. These are often ordered in patients who are having a hard time getting pregnant. They've been doing their 12 months, you'll learn all that stuff in GYN when you would order these studies. We're trying to figure out, like, why, right? Are we having an issue with the egg getting down into the uterus and that's why we're not getting pregnant? I don't know. We need to know structure that the fallopian tubes are patent and are working. Sometimes this is diagnostic because the pressure of the contrast will pop that fallopian tube open. And what you'll see often is you'll have a patient who's having a hard time getting pregnant, you're trying to figure out why, you order the HSG, it comes back normal, and you're like, well, there's nothing wrong with you, the fallopian tubes are open, and within 6 weeks they're pregnant. They had an issue with their fallopian tubes. By you ordering the study, it opened them up. You never saw the abnormality because it opened them up from the pressure of the contrast, and they got pregnant within the next month or two. And that happened to me twice. Twice. What's that? How many got? 3. It didn't happen to me. It happened to me as a provider. I don't have fallopian tubes. I did not give birth to my children. Anyways, so HSG, hysterosalpingogram, is your study of choice when you're trying to eval the fallopian tubes and that reproductive tract. Here's another study. Again, a little bit kind of like little torches, but it kind of spills out, because when you get to the end of the fallopian tubes, they're not connected to anything. Right? Those fibulae are just sitting there, just spills out into the intra-abdominal area. Septic uterus. So uterus split in 2. It does increase the risk of miscarriage, right, if you can imagine, but you can have 2 babies in there. It can happen, which is part of what increases the risk of miscarriage. It can even happen, by 2 different daddies. It can happen. And there are some cases out there of that. If you go on a little bit of an internet deep dive, you will find cases of women with septic uteruses, or uteri, who end up having twins or babies, but it's 2 separate biological fathers. Because they act as their own. It's just not common. It's extremely uncommon, actually. What do you guys have after this? Nothing? We have like 6 slides. You want to power? Yes. Okay. All right. So here's what a uterus will look like on ultrasound. Okay. Here's my normal uterus. It has the fold there. Got the ultrasound. There's the cervix will be like right around here, and then coming into the uterus. So here is the cervix area, and then this is the fold into the uterus. There's the uterine tissue. This is one here with an IUD placed. So that's what that is. A lot of times you can see the IUD on CT as well. Sometimes X-ray, because there's copper IUDs, and if you have a copper one, you might see parts of the T on X-ray. Just depends. But this is your ultrasound of your uterus. This is how you can actually end up measuring the cervix. You guys don't have to worry about that. You're not going to measure the cervix, but just kind of showing you. They look for where the cervix is, kind of now you see it better here, and they've got the yellow lines. And then they measure from the cervix to the inner canal area of the uterus, and it's how they do their intrauterine pregnancies. Because they want to know how far the cervix is. They want to make sure when they're going to go do the IVF and everything that they get all the way into the uterus. You guys won't have to measure that, but it's another thing that the ultrasound is used for. But it's a uterus, so we're going to do ultrasound. What do we got here? We got some babies. Where are my babies? I have one in my uterus. I have one that's not. So this is a simultaneous, they call it, I think, a heterotopic pregnancy and an ectopic pregnancy. So, these are some of the things you may find on ultrasound. Biggest thing, right? Female pelvic organs are ultrasound. Unless they're not, this is one of them. The reproductive tract with the contrast is an HSD or a HSG or a hysterosalpingogram. The other reason that a female pelvic organ is not ultrasound is if you suspect ovarian torsion and the ultrasound was done and it's normal, but you still suspect torsion, you're going to do the CT. But if no imaging has been done, it's an ultrasound. Testicular torsion, ovarian torsion, we just talked about. Study of choice, I just said it, ultrasound. This is showing you another male urethral stricture. And you officially know everything you need to know about radiology. All right? Before I let you go, one of the things in the break I forgot to mention is somebody had come up and they said I surprised them with something. I'm going to give you a quick cliff note of what it's like in phase 2 and studying and stuff, because somebody had asked me, they thought it was just clinicals, right? They're like, hey, I thought we just like see patients. There's tests. There's also tests, okay? And the way you study for those tests, how many of you looked at a syllabus in here for this course? For any of these courses? Wow, more than usual. That's great. I didn't touch a syllabus in phase 1. I just studied the damn slides, right? Phase 2, you need to use the syllabus.